Good evening, everybody. I'm Chris Pettit. I'm the president of the Congenital Cardiac Research Collaborative, and I'm really excited to kick off our webinar tonight and to introduce what I think will be a really compelling and exciting program. My job is really simple. I will be introducing sort of the concept of what CCRC is, and then handing this off, this webinar to be sort of emceed by Caitlin and Will Hamill. So the CCRC is a multi-center collaborative. These are the centers that currently collaborate together to and comprise the CCRC. But the CCRC began back in 2015 when these four dapper gents began to work together to search for the best way to treat rare forms of congenital heart disease. Initially, we focused on interventions, therapies that happened in the cath lab, but we quickly began to focus on forms of heart disease and look for any way any type of therapy, whether it was surgical or transcatheter. We fast forward to 2021, and currently the CCRC is comprised of participants from 12 centers across the United States, and not only interventionalists, but surgeons, intensivists, imagers, and other types of cardiology team members. The mission of the CCRC is to improve outcomes for patients with congenital heart disease across their lifespan. We want to improve quality across the country, not just at any one center, and to establish benchmarks for congenital heart disease based upon the COG model of longitudinal tracking. Our values are that we try to be equitable and we share responsibilities and share credit across our team. We try to be democratic, and so we rotate responsibilities and credit. We really navigate towards effective individuals, and we pride ourselves on being consistent at a high level. We've enjoyed a lot of success in the years since we began in 2015. We've had over 21 publications, a number of research presentations, and our group has been recognized with a bunch of awards over the past several years at AHA and the like. Our approach to research is perhaps not that novel, but it sort of follows our interest, and that is that we'll take on a main study and almost as a rule, other questions pop up as a result of that main study. And this sort of happens organically because when we think about success in congenital heart disease, we start to think, well, what do we care about? And oftentimes it starts with the newborn, like the photo on the left. And we care about what happens to that newborn with congenital heart disease. Well, we hope that the newborn survives, has effective therapy, and is able to go home. But that's not where our interests are completed. We want to know, what is the infant like as a 1-year-old? Are they thriving? How many operations have they had to undergo? How many days have they been home in that first year of life? And are they growing? Are they thriving? And even further than that, what about when they get into the school age period of time? How are they doing in school? Again, what has been their burden of interventions? Have they been meeting milestones? Do they have special needs? All of these are events and outcomes are important to us. And so when we think about what outcomes we care about, we kind of care about all of them. And so when we think about the projects we've taken on over the years, our research kind of reflects that wide interest. So when we look at any one of our main studies, we have a number of subsequent studies which spill over from that main study. There are a lot of unknown unknowns. And so in 2021, this may be a little bit shocking to some of you, but we still don't know the best way to treat congenital heart disease. In 2021, it's fair to say we know a number of ways that we can treat congenital heart disease, but we don't know the best way to treat most forms of congenital heart disease. And so in the CCRC, we really want to study innovations, and there's a couple ways to be able to do this. If we look at this diagram here, which shows sort of the lifespan of a person from fetus through infancy, childhood, into adulthood, with the timeline going from left to right, you can see that there are many events that might accompany a child along their journey from fetus to adulthood. They may have a fetal diagnosis of congenital heart disease, maybe even a fetal cardiac intervention. In the infancy period, they may undergo neonatal congenital heart disease repair, a neonatal palliation, like a ductal stent or a BT shunt. In childhood, they may have reinterventions, subsequent hospitalizations, different medical therapies. And then there are many events that happen in the adulthood period as well. Reintervention, heart failure, functional health. When we think about how to study innovation, we use these very small viewpoints that are in the form of registries that exist right now. We can have a very small viewpoint, which is around the time of infancy, often at the time of a neonatal congenital heart repair, or maybe even later on in childhood, where around the time of an event, a small slice of time is captured and data is captured around that event. This leaves us with most of the lifespan unrecorded and uncaptured. We can overcome that challenge of those multiple tiny little slices by looking backward. And so if we think about where we are right now in 2021, if we wanted to get an entire span of time without taking small slices, but get the entire time span, we could go backwards from 2021 and go all the way back and get 10 years worth of experience. And so neonates born in 2011, we could have all the time period between 2011 to 2021. This leaves us with the challenge, though, that we can only look at innovation and interventions that are performed in 2011. So any new therapies, any new technologies that have come into play after 2011 would not be captured in this retrospective approach. So there's a gulf that exists between the registries, which obtain those small slices of time, and these are observational and always in the present tense, and this retrospective approach, looking backward into the past, where you get a large span of time, but your innovations are always outdated by the time you're able to report on things. And we really want to expand the window of what do we care about. Many of the US News rankings, other benchmarks for our field are based upon 30-day survival from certain types of congenital heart disease. But the CCRC group is comprised of members who care about so many other endpoints besides just 30-day survival. And expanding the window of outcomes is what we are really interested in doing. So this leads to CCRC 2.0, kind of a reinvention of what we'll be doing. And Dr. Andy Glatz will be discussing CCRC 2.0 a little bit further in the presentation tonight. CCRC also has important partnership with the community, and it's really my pleasure to introduce some of the members of our CCRC community in the next few minutes. We have strong partnerships with CHD families, and as a result, and maybe part of the reason we have such strong partnerships with CHD families is that we really try to undertake patient-centered research. In the past few years, we've organized a family advisory board, which really guides and has a strong role in CCRC direction. The chairs of the FAB, or the Family Advisory Board, are Will and Caitlin Hamill, pictured here on the right, with their daughter, Kennedy, who I've had the pleasure of being her cardiologist since she was a newborn baby. And I will now turn over the presentation to Caitlin and Will. Thank you both.
Chris, thank you so much for that introduction. Families, welcome. Doctors, welcome. Thank you guys all for joining us tonight. We've put together a neat program and hope that you will enjoy it. We've been a part of this group for a number of years now, and ultimately had the opportunity to be a part because of a heart surgery and multiple heart surgeries that our daughter had. She ultimately was seen by Dr. Pettit, and we live here in Atlanta and have had the opportunity to be involved in this group from Atlanta, but there are many families that are a part of the conversation tonight and a part of our regular CCRC meetings all across the USA, and are able to contribute both their thoughts and ideas on how the research should move forward, but also fundraising opportunities, and then helping to put together a night such as this, where our goal is to spread the research. We received some of the research when we were making decisions for our Kennedy, and those decisions and that research was very, very helpful for us, and we want to make sure that other families have the opportunity to engage with the research, listen to the findings, and then also make informed decisions on their own. So I'll turn it over to Caitlin, who has some thoughts on tonight.
So just a quick overview of the evening. We've already heard from Dr. Pettit, who's the president of the CCRC, and shortly I'll turn it over to Dr. Brian Goldstein, who is the vice president of the CCRC. We will also hear from Dr. Athar Qureshi, Dr. Amy Glatz, and also have the opportunity to hear from some of our heart families that are involved on the Family Advisory Board. You'll hear from ourselves as well as the Vorps, the Raboris, and Carl Hamilton. So looking forward to a fun evening. And at this time, I will introduce Dr. Brian Goldstein, who's the vice president of the CCRC, and he's the lead author of the published manuscript, Management of Neonatal Symptomatic Tetralogy of Fallot, Findings and Implications. So Brian, turning it over to you.
Thank you, Caitlin. Thank you, Will. It's really a treat to be here tonight and have the opportunity to share some of our research and experience in the tetralogy flow space with the greater community. But first, let me just thank our multiple collaborators within the CCRC, investigators and families, and those who have been willing to spend time on this webinar session tonight. And as or more importantly, to those who have joined or will be joining later, watching a replay of this evening session, thank you so much for committing some part of your evenings to join us and hear a little bit about Tetralogy of Fallot and the CCRC team, what we're doing now and what we're doing in the future. Lastly, a shout out to Justin Shredder and Ali Barnes, who lead the Heart University platform that is so graciously presenting this this evening. So on to Tetralogy of Fallot. First, a brief primer of what is Tetralogy of Fallot. Well, it's really a single abnormality that results in four major clinical findings. One is the presence of a ventricular septal defect, or VSD, the presence of an overriding aorta, and resultant pulmonary stenosis with right ventricular hypertrophy. Tetralogy of Fallot impacts 3 to 5 out of 10,000 live births, making it a rare disease, although it accounts for 7 to 10% of all congenital heart disease, making it a common form, and in fact, the most common form of cyanotic congenital heart disease. It affects males and females equally. It was first described in 1671 in Paris, but more elegantly described later by Fallot as La Maladie Bleue, or the blue disease, in 1888. It was later coined Tetralogy of Fallot by Maud Abbott, who was working in Montreal in the early 1920s. And the disease has a multifactorial etiology, including genetic influences. So Tetralogy of Fallot comes in different forms. Here we have a pink fish and a blue fish, pink representing the well-oxygenated patient with tetralogy, and blue, the cyanotic patient with tetralogy. And the pathway of management for the patient who is well-oxygenated, it tends to be elective repair at 4 to 6 months without the need for an intervention beforehand. The population we'll discuss tonight is the cyanotic infant, or the infant, the neonate with symptomatic Tetralogy of Fallot, where generally an urgent neonatal procedure is performed to improve cyanosis. And that procedure can take the form of a corrective surgery where the entire disease is repaired, or it can take the form of an initial palliation to augment pulmonary blood flow, followed by later repair. So one might ask, isn't the management of symptomatic Tetralogy of Fallot an old debate? And indeed, this dates back some time. In November 1944, Eileen Saxon was an 18-year-old girl who had Tetralogy of Fallot, and she was the first patient who received a Blaylock-Thomas-Taussig shunt. Alfred Blaylock, depicted on the left of the inside of, below right of the screen, Vivian Thomas and Helen Taussig, cardiologist. This was the team that pioneered the first blue baby operation and really allowed the field of congenital heart surgery to be ushered in. And that sort of heralded the era of ultimately repair of Tetralogy of Fallot, whereby a patient underwent a BTT shunt, or more recently a modified version of that with a Gore-Tex tube between the aortic and pulmonary circulations, followed by later complete repair. And in the 50s, 60s, and 70s, that complete repair was really not undertaken until at least 4 to 5 years of age. If you fast forward into the 70s and then certainly into the 80s, led by John Kirkland and Aldo Castaneda, working at Mayo and then Birmingham for Kirkland, and then Castaneda in Boston, that really pioneered the field of neonatal congenital heart surgery, whereby a patient with tetralogy could undergo a complete repair in their infancy. And that sort of changed the field, such that if you look at these data from Boston on the left and Michigan group on the right, into the 80s and 90s, it was clear that complete neonatal repair of tetralogy of Fallot could be accomplished and could be performed safely, such that there was a less than 10% mortality over several years postoperatively in these two early cohorts. However, there was some price to pay for that neonatal repair, and in these slides depicting the freedom from reintervention, by the time one is out 5 to 10 years or 5+ years, there is nearing a 50% incidence of reintervention. And so the question has long remained as to whether primary complete repair is the right thing in a symptomatic neonate or is palliation, although in the larger centers, I think it became clear that this was typically favored, but not all centers, and it remained a point of contention. However, the debate, I think, either emerges or reemerges more recently, and this is a pictorial representation of some of the drivers of this reemergence of the debate. On the left panel, the sort of concept of the advent of less invasive palliation strategies with as good or better outcomes. And here's a PDA stent depicted, but there are other transcatheter palliative strategies, including right ventricular outflow tract stents and balloon pulmonary valvuloplasty. In the center, really increased scrutiny on late outcomes. Early studies focused on early mortality, then medium-term mortality, but late outcomes such as neurodevelopmental status, school performance, functional assessment of the patient with exercise testing, functional assessment of the ventricle or the pulmonary valve, the need for reinterventions, including pulmonary valve replacement, all increase focus on this debate. And lastly, and more recently, there's been a large impact of transparency focus in our field of public reporting, and the sort of one end game of this public reporting concept, which is hospital rankings, which in part are derived based upon surgical outcomes. And this plays an important factor on the reemergence of this debate. So what modern data informs this debate? Well, really the gold standard is the presence of a randomized clinical trial whereby patients are assigned to one strategy or another, and we see what happens. And of course, in this field, there are none, and that's important. So we look to retrospective data, and this is the first really major large data set derived from multiple centers through an administrative database called FIS, which is a collection of children's hospitals who report administrative data, including cost or charge data, as well as some coding data to identify patients and some clinical data, but limited. This was a study put together by the CHOP group and published a couple of years ago, which demonstrated in the left panel with early survival and in the right panel with survival to 2 years that the stage repair group, which shows up in the orange tracing, that group performs better. They have a better probability of survival early and at medium term. The challenge with this data set are a couple-fold. One is it's an administrative data set with limited clinical data, and that makes it a little bit challenging to adjust for differences in the two cohorts because we just don't know everything there is to know about those patients. Further, and potentially more importantly, that study was at risk for incomplete capture of deaths that occurred outside of the hospital. So deaths would be more likely in the interstage in the group that didn't have a complete repair. And this database really only captures in-hospital data. And so that's an important miss in that data set that could account for the difference between these populations. So our group just recently published in the Journal of the American College of Cardiology a comparison of management strategies for neonates with symptomatic tetralogy of Fallot. And we'll spend the next several minutes discussing our findings and then move into the implications. So this study was performed at the 9 centers of the CCRC at the time, including patients from 2005 to 2017. There were 572 symptomatic neonates with tetralogy of Fallot who underwent either primary complete repair in 230 patients or a staged approach to repair with an initial palliation followed by later surgical repair in 342 patients. The overall cohort we've seen of the 342 patients who underwent a staged approach to repair, 256 underwent a surgical form of palliation. The vast majority were aortopulmonary shunts or BTT shunts, and a smaller minority underwent transcatheter palliations, including RVOT stent, balloon pulmonary valvuloplasty, and PDA stent. And if you look overall at the cohorts without any adjustment for differences between the groups, which was subsequently performed in the next slides, there were no heart transplants, and there was a 10.2% incidence of mortality in the stage group and a 7.4% incidence of mortality in the primary repair group across the follow-up period, which was not significantly different between the groups. When we get into more nuanced statistical analysis with adjustment of data here in these survival curves, there is again no difference between the groups in the hazard of mortality. However, when you look at the vertical dashed line, which defines the 4-month period, there was a significantly increased risk of mortality in the primary repair group in that first 4-month period. So early mortality favored the staged repair approach, whereas the later risk after that 4-month early period, there was no difference between groups. We look at the cumulative incidence of reintervention here between the two groups, and it becomes apparent quite readily that there's a significantly increased risk of reintervention in that stage repair group. That was the group that had a reduced risk of early mortality a slide ago. And when we look at the first 3 months after the first intervention, it's evident that the risk is higher in that stage repair group in that first 3 months. But after 3 months, there is no difference between groups. And when we look at the risk of reintervention after the definitive repair, so this is after both stages in the stage group or the only repair in the primary repair group, there's no difference between the cohorts across subsequent follow-up. And we look here at some continuous outcomes like ICU length of stay on the left and the duration of blood pressure medicines on the right. And it's apparent that in the initial or individual stages of the stage repair strategy, that ICU length of stay is shorter and the duration of blood pressure medicine is less so in the stage repair groups for each component. But when one looks at the cumulative amount of length of stay in the stage repair group, it's actually higher than the primary repair group. So that cumulative length of stay is longer. And the cumulative exposure to blood pressure medicines is not different from the primary repair group. Here, looking at duration of cardiopulmonary bypass exposure on the left and anesthesia exposure on the right, one can see similar trends where at the initial palliation, there's a reduction in the stage repair group compared to primary repair. However, when looking at both the complete repair and therefore the cumulative component of stage repair, there's an increased exposure to cardiopulmonary bypass and anesthesia in that stage repair group. And then looking at the adjusted effect of the treatment strategies on what we call dichotomous outcomes here, in-hospital mortality at the top, procedural complications in the middle, and hospital complications in the bottom, one can see that individual components of the stage repair strategy favor stage repair, that there's lesser in-hospital mortality, procedural complications, and hospital complications at the components of stage repair. However, when one looks at the cumulative strategy and compares them, there is no difference in those outcomes. We do have some limitations of this research. First, it's a retrospective study. It's not a clinical trial. As we alluded to, there aren't clinical trials in this space yet. We're not able to control for all potential confounders. We measured lots of different patient variables, but we can't possibly measure every one retrospectively. And we can't account for practice variation like differences between centers that may affect outcomes that are difficult to ascertain in a retrospective study. We don't have certain critical long-term outcomes, and we'll get into a little bit of that with Dr. Glatz's presentation in a bit. We have lumping of palliation types, so we don't tease out in this study the difference between, let's say, a transcatheter palliation and a surgical palliation. And really, we have underrepresentation of key transcatheter palliations, including PDA stent and right ventricular outflow tract stenting. So in summary, early mortality, procedural complications, and neonatal morbidities or exposures to high risk things like ICU length of stay or bypass time, those all favored the stage repair strategy. But late mortality didn't favor either strategy. Early reintervention favored primary repair, while late reintervention was equivocal between the groups. And cumulative, the total amount of morbidity exposure favored primary repair. So to conclude from our study, stage repair is associated with lower early mortality and less neonatal morbidity, which has potential implications to neurodevelopmental outcomes, knowing that early life exposures to the developing brain in the first month of life are outsized compared to those exposures later on in life. They also have implications to public reporting, which looks at things like early survival after neonatal heart surgeries. Primary repair is associated with less cumulative morbidity and fewer reinterventions, which has potential implications to neurodevelopmental outcomes as well from those cumulative exposures, quality of life by spending more time out of the hospital, and also the cost of care. It's just less time in the hospital and less stuff done to the patient. Two strategies presented here have equivalent medium-term survival, and that's really a key and striking finding from this data set that has important implications to decision-making as well. Future directions, and we'll get into this with Dr. Glatz's presentation. We didn't look at important things that occur late to patients, and we'll cover those in a bit. And then what's next? Where do we go from here? Do we need to perform a randomized trial or do some other data collection process? Well, this study is a representation and a result of the involvement of a huge amount of people, many of which are pictured here, but not all. And I just wanted to specifically thank Joelle Pettis, Courtney McCracken, and Michael Kellerman from the Data Coordinating Center for the CCRC, as well as funding sources, including the Hamill Pediatric Cardiac Research Fund, the Children's Healthcare of Atlanta and Sibley Heart Center Group, Liam Sexton Foundation, Heart Like Ava, the Vickers family, and the Sawyer Family Charitable Giving Fund. So with that, I will pass the microphone back to our moderators, Caitlin and Will Hamill. And thank you very much for joining us tonight. And we hope the rest of this session is very exciting and important. Thank you so much.
Thanks, Brian. Now I would like to introduce Dr. Athar Qureshi, who is the CCRC New Studies Chair and the lead author of Management of Neonatal Symptomatic Tetralogy of Fallot and Low Birth Weight Infants.
Good evening. I would like to thank Hart University and all of you on behalf of the CCRC for this exciting opportunity. It is wonderful to be here with all of you, and especially with all the families and friends who do such amazing work caring for patients with congenital heart disease. I'll be talking about management of neonatal symptomatic tetralogy of Fallot and low birth weight infants. I won't be talking about details of tetralogy of Fallot, which Dr. Goldstein has just nicely covered, but I will talk about why there is a need to study low birth weight infants with congenital heart disease. So what is the definition of a low birth weight infant? Low birth weight infants are babies who weigh less than 2.5 kilograms at birth, or 5 pounds, 8 ounces. And as you can see on this graph here to the right on the screen, babies who are born at term are considered small for gestational age if they are less than 2.5 kilograms. Babies who are 1.5 kilograms to a gram, 1 kilogram are very low birth weight infants, and those below that are extremely low birth weight infants. There are really two causes for low birth weight infants. One is prematurity, and of course that brings along inherent risk factors. And the other is fetal growth restriction. If a baby is born at term, one has to question why the baby is small. And of course that also is a result of significant risk factors in utero. Low birth weight infants carry a number of risk factors, and these are some of the risk factors that low birth weight infants can have. They may have low oxygen levels, which can compound the effects of complex congenital heart disease. They can have difficulty controlling their temperature. Feeding and growth issues are very important, as this can inhibit or delay the process of healing after major procedures. Many of these babies are prone to infections, and they can also develop respiratory distress syndrome due to immature lungs. In addition, many of these babies have neurologic problems resulting in intraventricular hemorrhage in the brain, and gastrointestinal problems such as necrotizing enterocolitis, which can also complicate the course of babies with congenital heart disease. Low birth weight infants also have smaller structures, and these can potentially be a risk factor for prognosis in the short and long term. In addition to that, smaller structures may result in technical constraints for various procedures that are being performed due to the smaller structures these procedures are performed on. And you can see in this picture here, this is a little diaper of a very low birth weight infant who was less than 1 kilogram in whom we performed a procedure. So this picture just gives you an idea of the small structures that we are dealing with when taking care of these patients. So what is known when we talk about very low birth weight infants, low birth weight infants with congenital heart disease? So this is a study from the STS database, and they looked at more than 3,000 infants in the study. And you can see here that in most categories, these are risk categories dependent on the type of lesion and surgical procedure being performed. And you can see that almost all across the board, there was a significantly higher risk in babies who were 1 to 2.5 kilograms undergoing congenital heart surgery. This is another single center study in which the authors looked at more than 750 infants weighing less than 2.5 kilograms. And comparing them to 2.5 to 4.5 kilograms. So the total cohort consisted of 750 patients. And you can see the breakup here in the center of the screen. And you can notice here that there was a significantly increased risk all across the board, almost in all of these risk categories in these babies who were less than 2.5 kilograms undergoing congenital heart surgery. What about lesion-specific data? So we know that there is higher mortality in infants less than 2.5 kilograms undergoing the arterial switch operation. However, another group found that there was no difference in infants undergoing an arterial switch operation if they weighed less than 2.5 kilograms. It is noteworthy, though, that in both of these experiences, the mortality was driven by infants or babies who were less than 2 kilograms. In babies who underwent the Norwood stage 1 procedure, who were less than 2.5 kilograms, favorable results were noted with regards to mortality and morbidity when compared to larger babies. So you can see here that the data is sort of all across the board, and there's very little data with regards to tetralogy of Fallot. So I'm going to move on to our CCRC study, in which we looked at small babies with tetralogy of Fallot. So this is an article in Press that was, at the time, the data came from 9 sites at the time, looking at the comparison of management strategies for neonates with symptomatic tetralogy of Fallot and a weight of less than 2.5 kilograms. And I'll go over some of the data. So the overall cohort, as Dr. Goldstein presented, was 572 patients, and 230 neonates underwent primary repair, and 342 underwent initial palliation as part of a staged procedure. Of those weighing less than 2.5 kilograms, in the primary repair group, there were 44 patients, and in the initial palliation or stage repair group, there were 76 patients. This is just a cartoon depicting those patients who underwent a primary complete repair and those patients who underwent a stage repair. In this diagram, you can see a BTT shunt has been constructed. Most of the patients in the stage repair underwent surgical procedures in our cohort. However, there were a number of patients who underwent transcatheter procedures such as a PDA stent, RVOT stent, or balloon pulmonary valvuloplasty. The primary outcome for the procedure was death, and we noted no significant difference in mortality when we compared the primary repair group and the stage repair group. Noteworthy, less than 4 months of age, we also noted no difference, although it could well be that our numbers were small, so we couldn't tease out a difference between these groups. But these findings are different than the findings from the primary study presented by Dr. Goldstein, in which the early mortality favored the stage repair group. The primary outcome of death, you can see the overall mortality at 5 years was 17%, and this is very sobering. This is something that we don't often think about when we talk about neonates or babies with tetralogy of Fallot. But as you'll hear throughout this session, we want to look beyond just the early mortality and look at the overall mortality and how these children are doing in the long run. There was no difference between the primary repair and stage repair group. And you can see here this depicted on this cartoon with these children playing on a seesaw. However, what was different was that the mortality rate was quite different in our study compared to the study presented by Dr. Goldstein, in which 10% of patients in the stage repair group and only 7% in the primary repair group had died. This slide looks at a series of box and whiskers plots. And in this slide, we are comparing primary repair with the different components of the stage repair group. And we looked at the ICU length of stay, hospital length of stay, duration of ventilation, duration of inotro, and these were measured in days. And we also looked at the duration of cardiopulmonary bypass and the duration of anesthesia, and these were looked at or measured in minutes. And you can see here that overall, the cumulative morbidity, so the cumulative morbidity over time, when you compare the primary repair group to the different components of the stage repair group over time, overall, this cumulative morbidity favored the primary repair group. However, when you looked at ICU length of stay and hospital length of stay at the initial palliation, so at the first step of the stage repair group, and we compared that to the primary repair group, there was no difference in the ICU length of stay and hospital length of stay. And you can see here on this cartoon, seesaw cartoon, that this was really equal in the primary repair group and stage repair group. And these findings were also quite different than the findings from the study presented by Dr. Goldstein, in which the ICU length of stay and hospital length of stay favored the stage repair group. We looked at reintervention overall as well, and what we found that there was no difference in the reintervention burden when we looked at the stage repair group and primary repair group and looked at the incidence of reintervention over time. And these reinterventions included both surgical and transcatheter reinterventions. And these findings were also different than the findings from the primary repair study, in which there was a higher early reintervention in the stage repair group. So what is the take-home message of this talk? In this fragile patient population, I think the high mortality is extremely sobering. When we talk about a mortality rate of tetralogy or below of 17%, that is extremely high, and it's really not something that even we as healthcare professionals think of. As is evident from this talk, low weight is at least as important and maybe more important than the treatment strategy for these babies with tetralogy below. Randomized trials and prospective registries are necessary to further compare management strategies. So what did this all mean for me or for you as a family member or a loved one who may have a child with tetralogy below? For example, what if you had a baby who's 1.8 kilograms with tetralogy below and who is symptomatic? Well, it's important to remember that no patient is an average or a cohort, and one must take into account the local experience with this lesion and also the local skill set of taking care of very small babies, both from a technical aspect and also with regards to the recovery of the baby. Thank you all for your attention.
Thanks, Athar.
Thanks, Dr. Goldstein. Now we turn the segment over to some families to give you our perspective. Certainly, as I listen to the research and the data, to some degree, as a parent, it goes a little bit over my head. And so for those families that are joining us tonight, thank you very much. We're going to have some of our doctors kind of summarize for you just a little later in the presentation. But I want to introduce the families that are going to give their perspective tonight. You see there in the top left, Becky and Brad Vorp with their 3 kids, Ryan, Jackson, and Nicholas, also pictured there at the bottom of the page. They have 2 10-month-old boys who have had a variety of heart surgeries, and they're coming to us from Pittsburgh, and we'll be giving their perspective. Also joining us tonight are Stephanie and Brian Rabori. Stephanie and Brian have a 6-year-old girl named Madeline, who has undergone several heart procedures. And so they'll give their perspective, and Stephanie will also give her perspective. Stephanie is 26, just had a birthday, and ultimately has had repairs done to her heart in her life when she was much younger. So happy birthday to Stephanie. Happy 26th birthday. We've got Carl as well. Carl's 22. Carl lives in Philadelphia and goes to Dickinson College. And Carl just had a valve put in somewhat recently via the cath lab. So interested to get his perspective. And then you see Caitlin and I there at the bottom with our baby girl Kennedy in white, who is 4.5. We'll give our perspective as well. So with that, I'll turn it over to Becky and Brad. Thank you both for being with us tonight. Excited to hear from you.
Thank you. I appreciate that. Hello, everyone. As they said, my name is Becky, and this is my husband, Brad. And this is kind of our story with Tetralogy of Flow. So we have a 2.5-year-old son, Nicholas, at home. And last June, we welcomed our twin boys, identical twins, into our family. Last April, when I went to my 20-week ultrasound, and of course, because of COVID, Brad was not able to come with me. He was on FaceTime, though, thank goodness. Not only did we find out at this appointment that we were having boys, but we also found out that not one, but both of our twins had some degree of tetralogy of flow and had multiple echocardiograms done throughout the rest of my pregnancy. Although this was absolutely devastating and terrifying to find out this about our twins, it did give us time to wrap our heads around of what to expect and what their first couple months of life may be like. Our goal was for me to make it to 37 weeks, but unfortunately, I went into premature labor and they were born early at 31 weeks and 5 days. So on top of all their heart issues, they now had prematurity issues as well. Ryan weighed 3 pounds 9 ounces and Jackson weighed 4 pounds 1 ounce. Initially, the plan was to potentially do a full repair at birth, but with them coming so early and being so small, we needed to delay their repairs until they were bigger and stronger. Ryan was initially started on prostaglandins, and at 22 days old, he had a stent placed in his PDA. Jackson had, at 15 days old, a stent placed in his right ventricular outflow tract. Both were done in the cath lab here in Pittsburgh. Needless to say, despite many ups and downs, including Jackson developing NEC, which required emergent surgery and a colostomy for 3 months, some aspiration issues, as well as some other issues that we went through while in the NICU, especially during COVID times. We were able to bring both of them home after about 2 months in the NICU. And I believe that if it wasn't for these stents and the research that we have now to do the stents, we would not have been able to bring them home as early as we did. So in total, both Ryan and Jackson went to the cath lab twice and got blood transfusions before we finally were able to do their full repairs in October, just after they turned 4 months old. Jackson had his surgery on Monday and Ryan had his the following day on Tuesday. This may have been one of the most stressful weeks of mine and Brad's life, but they did amazing. And they were discharged. Ryan was discharged after 6 days from his open heart surgery, and Jackson was discharged after 10 days. As they said, they are now 10 months old and they're doing fabulous. There is never a dull moment in our house with 3 boys, but we wouldn't change that for anything. With that all being said, we are very excited for the research that is being done on tetralogy of flow. With our kids being so young, I will imagine that they will need some interventions as they grow. And it is exciting to see what all is out there and the new ways of doing things with the research being done so that we will be able to make the best decisions for our boys as they grow up. Thank you very much for your time and inviting us to share our story with you today. They truly are our heroes, and we can't wait to see what more comes from all of this. Up next, I'm going to pass it back to Caitlin and Will Hamlin, and they're going to give you their story.
Thanks, Becky. So our daughter Kennedy, she has something a little bit not like tetralogy of flow. It's in the same family, but more severe. But we were fortunate when she was born, based on the research that Dr. Pettit had at the time. She was born in October 2016. We were able to stent her PDA shortly after birth to prolong open heart surgery. So she was able to have a full repair at 4.5 months of age. And then a second open heart surgery at 2.5, and she is now 4.5. Unfortunately, she does require frequent reintervention in the cath lab, but we were fortunate to have been under the care of Dr. Pettit for so long until he sadly left us to go to New York. We've forgiven you though, but she's had 8 cats with him, and we've been incredibly fortunate to have gone down the path that we did, because she's had 0 developmental delays, and she's a normal 4.5-year-old that loves to play and keep up with her friends. So we are very fortunate to have been under the care of Dr. Pettit, and so thankful that we can then now try to give back and be involved with other families to help disseminate this important research that they are sharing with us. So I'll turn it over to Will.
My only comment would be that I'm just excited to see multiple centers coming together. As I understood some of the prior research, it's center by center, and to see multiple centers coming together to look into different issues is great for families, because it provides more data to make informed decisions, to be able to discuss with the providers and make the best decision for each patient based upon both the location of the patient, but also the research as to what sort of intervention is best. So thankful to all these docs who have come together to work together and figure out the best means of recovery for patients. With that, I will turn it over to the Labores.
Hi. Hello, everyone. I'm Stephanie.
And I'm Brian Rubori. And about 6 years ago, we became parents of a heart warrior.
When I was pregnant, just like the other families we're talking about, we found out that I was 20 weeks, and Madeline did have the same thing as me, which is tetralogy of Fallot, and they found that when I was pregnant, and that she would be surgically repaired about 5 days of life. And on that 5th day of life, we were given the diagnosis of tetralogy of Fallot with pulmonary atresia, hyperplastic pulmonary arteries, and MAPCAs.
Do nothing was the original treatment plan, and say goodbye in about 3 months was the prognosis. We wouldn't accept that option, and we did our own research online. Countless hours were spent online searching Google, reading journal articles, and calling different medical centers. Ultimately, we decided to make the drive to Cincinnati Children's Hospital.
The reason why we chose Cincinnati is because 30 years ago, I was a patient there, being a TOF kid and now adult. And I received corrective surgery for my tetralogy of Fallot as well. After all this time, my cardiologist was still there with the hospital, and he was wonderful. And he looked over Madeline's medical records and gave us hope, and gave us faith, and that there was a lot that could be done. And except he was retiring in 2 months. And so he told us about Dr. Goldstein, who has been a godsend, and he took over for Madeline, and he's been with us ever since. So
Madeline had her first intervention with Dr. Goldstein on her 2nd-month birthday. 15 catheterizations and 7 surgeries later, Madeline is now getting prepared for her complete repair over the next several months. This isn't the road we wanted to take, but it was the road that we had to take to get the results that Madeline needed.
While consulting with different pediatric cardiology groups around the country, we were asked numerous times why the doctors we have already seen had not been keeping up with the current research. Of course, we did not have those answers, and we only had more questions on why the current research was not as far-reaching as it needed to be and as it should have been. The lack of information, knowledge, and current protocols would have drastically changed our lives had we not consulted with Cincinnati.
From our experiences, we learned that this research needs to be shared not only with the major medical centers, but also at smaller hospital groups, all pediatric cardiologists and general practitioners. This information also needs to be available as an easy to understand format, so overwhelmed parents, much like ourselves and everyone else here, could easily understand that information and make the proper decisions.
We've also learned on this journey, as the other parents have discussed, that we need to have faith and know, of course, all the parents out there, that you are not alone during this journey. We know exactly what you are going through, and you have to be your child's best advocate. You need to reach out to others, share knowledge and know-how, And it's what we've had to do for Madeline. We've had to be her best advocate. And it's what my parents had to do for me over 30 years ago, not 20.
We are encouraged to see the CCRC continue to grow, learn, and teach so tiny hearts can be mended through their research. Thank you for allowing us to share our part of our story with you. We understand what some of you are going through, and we're here to offer as much support as possible.
We're just happy to be a part of this.
So thank you, and now we
Thank
hand
you.
it off to Carl.
Hello, I'm Carl. As they said, I'm 22. So I was born in 1998, and I had my first major surgeries really in March and April of 1999, where I know I'm not kind of shaky on exactly what happened, but I know I had holes in my heart repaired, and then other surgeries to do with my valves, and things were not looking too good, but it eventually got fixed. So since then, I've had multiple interventions, mostly through the cath lab. In the mid-2000s, I had a stent put in, I think. I had that stent blown up in around 2010. And then in 2017 was my last intervention, where I had the Edwards Sapiens valve put in. And that was going to be an open heart surgery that I was fearful of. But a few months before that, Dr. Glatz called us up and said that that could be done through the cath lab. So instead of having, a month or so of recovery, through a procedure like that, it took me about 3 days of recovery, and I was back, and I started my senior year. So overall, I mean, it's my parents that have borne the brunt of this more than I have. I've just noticed, being 22 now, I've been able to participate in many athletic activities. I really have not felt inhibited by this. I have a little bit of a decreased stamina just in general, but nothing has really held me back from this. And, it's nice if I can provide any hope or kind of success story, you could say. And then even Stephanie, it's nice to see someone I've never really known of, someone that's been even older than I am. So that's great to see. And yeah, I was lucky to have great care at the Children's Hospital throughout my years in Philadelphia. And it's been a very good time.
Thanks, Carl. Thank you to all the families for sharing your stories. I know, like the Robori said, if there are any families out there currently watching, you're not alone. And if you have any questions for us or any of the other physicians that have presented their research tonight, please reach out to the website you see here, ccrcresearch.org. Happy to answer any questions that you have. I'd now like to turn it over to Dr. Andy Glatz, who is the CCRC Scientific Chair and the ITOF study lead for what's yet to come from the CCRC ITOF study. So Andy, turning it over to you.
Thank you very much, Will, Caitlin, and all the rest of the families, particularly to Carl. It's great to see you here. Hopefully we'll see each other in clinic sometime soon. My task over the next couple of minutes is to talk a little bit about what the future holds for both this Tetralogy of Flow study, as well as for some other issues for the CCRC. I think as you've already, sorry, my slides are not, let me try that again. All right, so as you've already heard from Brian and Athar, we have a really unique data set of data on nearly 600 neonates with Tetralogy of Flow, over half of them with follow-up data for more than 5 years. And so this is really going to allow us to hopefully answer a lot of questions outside of what you've already been presented. I'm not going to show you any data, but just to try to whet everyone's appetite for hopefully what you'll start to see coming out over the next 12 months with some of our planned ancillary studies. So one of the things that Brian alluded to is the use of cost as an outcome. We have the ability to actually link our data set with that phys administrative data set to actually look at costs, and we can compare costs from strategy A to strategy B, both for the index hospitalization and then in the first and 18 months of life, to see if there's differences in costs. Because if other things are being equal in terms of clinical outcomes, cost may be a relevant outcome, and we're looking forward to exploring that. One of the other things we plan to look at is among patients who have an initial palliation, so among patients who go down the stage repair pathway, is there a difference based on the type of physiology that's imparted by the palliation? There's a couple different options. You can create a physiology, something akin to a BTT shunt, or you can create a slightly different physiology by doing a stent in the right ventricular outflow tract. And so we're going to look to see if the different physiologies seem to have differences in outcomes. We think growth is very important, and so we'll be looking at differences in growth as well as the types of feeding regimens required to get that growth, comparing strategy A to strategy B to see if there's any important differences. This has also been mentioned before by some of the families, but children who are initially born with tetralogy of Fallot and very small pulmonary arteries are potentially a unique group that may have different outcomes depending on which initial treatment strategy is chosen. So we are going to be looking at that subcohort of patients who start with small pulmonary arteries to see if there's differences in the growth of those vessels as well as other outcomes based on the initial treatment strategy. You've heard a lot about the number of catheterizations and other tests that are required for patients with tetralogy of Fallot. We know that exposure to radiation, particularly in childhood and infancy, can potentially have some risks. So we're going to try to quantify this and look to see what is the total exposure to radiation in the first 18 months of life, and is there a difference in the amount of radiation exposure required to sort of get you through one treatment strategy or the other. Obviously, neurodevelopment is a really important outcome. We have a somewhat unique approach to looking at this. We're actually going to be mailing out or have mailed out surveys with quality of life and neurocognitive function inventories to have patients, parents, and families complete so we can answer questions about how are all these patients that we started following many years ago doing currently, what is their current neurocognitive function, what is their current quality of life, and are there differences in any of those things based on their initial treatment strategy? We also want to look at the late outcomes. We focused a lot in what happens early on in the first year or 18 months of life, but we have long-term follow-up data on a decent percentage of this cohort. So we're going to try to get some longer-term outcomes in terms of specifically the total reintervention burden over time, and some information on what their late functional status is like. And again, are there differences in any of those things based on the initial treatment strategy selected? Shifting gears a little bit beyond just tetralogy of Fallot, Chris alluded to this in his beginning comments, but the sort of next, the rebirth or rebranding of CCRC is going to be to create a prospective registry, and this really presents some unique opportunities to us. So currently, there's an organization called Cardiac Networks United, which can be thought of as either a sort of a network of networks or a registry of registries, where Cardiac Networks United can sort of assimilate data from multiple different registries and combine them together to do some unique things. So currently, Cardiac Networks United is made up of a number of registries, including a registry called PC4, which captures data on ICU events. There's another one called PAC3, which captures information from the step-down or ward or CCU. There's a registry called ACTION, which looks at patients with heart failure or patients who require a ventricular assist device. CNOC is a registry that looks at neurodevelopment. NPC-QIC is a registry that tracks patients with hypoplastic left heart syndrome. And PD-Perform is a registry that looks at data related to perfusion during an operation. So this constellation of registries, or this universe of registries, really captures a lot of information about a patient as they kind of go from one experience to the other. But there's some important things missing that we're hoping our registry can fill in, and that primarily focuses on what happens in the cath lab, which is not really captured in any of these registries, and then some longitudinal long-term follow-up. So we are now part of this network of networks, or registry of registries, and have the ability to then really track the patient's experience with heart disease over hopefully the entire lifespan. The initial plans for the CCRC registry is that we are creating or have created a module that looks specifically at newborns with a form of heart disease called ductal-dependent pulmonary blood flow, which basically means that there's inadequate pulmonary blood flow without a ductus arteriosus. It does include a range of anatomies, including patients with single ventricle forms of heart disease, but then also importantly, patients with two ventricle forms of heart disease, including Tetralogy of Fallot. So this will be our first module. They'll go into this registry and we'll be able to track them moving forward over time. Future modules will be coming down the pike. They have not been sort of finally decided, but the input and advice from our families and other advisors will be critical in making that decision. And then I'll end with one other new thing that's coming down the pike that has been really informed and inspired by the data both from this study as well as one of our prior studies. And this is the COMPASS trial. The COMPASS stands for a comparison of methods for pulmonary blood flow augmentation in neonates, shunt versus stent. This is a trial that is being run and sponsored through the Pediatric Heart Network, which is itself sponsored by the NIH. This will be a very unique trial. This will be the first ever multi-center randomized trial that compares a transcatheter intervention to a surgical intervention for children with congenital heart disease. Specifically, our goal through this trial is to randomize 300 neonates across 23 different centers in North America who fit into this category of ductal-dependent pulmonary blood flow. And subjects, babies, will be randomized to receive either a PDA stent or a surgical systemic to pulmonary or BTT shunt as a form of initial palliation. We will look at their outcomes over the first year of life, comparing these two different treatment strategies in the gold standard of a randomized trial. Importantly, in addition to patients who go into the trial, we will also create a companion registry, which will collect data on patients who do not meet eligibility criteria for the trial to learn important information on those patients, even if they can't be part of the trial. And the other thing that's somewhat unique about this trial is that almost all the data collection will be embedded within the existing registries of Cardiac Networks United, primarily with data coming from PC4 and the CCRC registry. And CCRC will have an important role in this trial. So with that, I'm going to end and thank everyone for their attention and presence, and have Will and Kaylin take over from here. Thanks.
Thank you, Dr. Glatz. Now we begin the question and answer session of the evening. And I first want to kick it over to our first presenter, ultimately, Dr. Pettit, who, if I can ask Dr. Pettit, for families out there that are listening tonight, could you summarize the research and summarize what we've heard?
Thanks, Will. Yeah, and thanks to all the presenters. It is to summarize all of what we just heard is, I think, a little bit challenging, but I will try to summarize the findings from the main study. And Brian, you can correct me where I sort of deviate from the party line a little bit. But what we found was a little bit different from what earlier research had maybe suggested. We found really that there was a lot of evenness or sort of parity or equalness between the two methods in terms of whether you, as a physician, take a baby with blue tetralogy of flow or who's cyanotic with tetralogy of flow, and either place a shunt or a ductal stent, or if you take them and do a complete repair right when they're a newborn baby. And the outcomes overall, when we look at, when they're older, were roughly equivalent. There were some small nuanced differences in sort of in some of the outcomes. What's really hard to do when you're looking back in time is always to sort of wonder why someone, there must have always been a reason. At all these centers, the clinicians, the doctors had a choice. They could have placed a shunt, they could have performed a ductal stent, or the option for a complete repair was always available for most of these babies, right? And so what's impossible retrospectively looking backwards to ever know is like, what were the subtle signals that made a center, made a doctor or a surgeon or a cath doctor to choose one thing versus another? Was it something about the size of the branched pulmonary arteries? I know one of the families asked about that. Was there a genetic issue, or was there, some other issue with like the intestines, or, some two different families mentioned necrotizing enterocolitis? Was there something like that which made the medical team want to delay the need for a complete repair and just do a place a ductal stent or a shunt? So we try to control for those things, but that's always fraught. Like, you can never really 100% account for those things. So the best we can tell, there's rough equalness between these two approaches. But again, we're trying to use statistical methods to kind of try to level the playing field between these two groups of newborn babies: the ones who had, a palliation, meaning a shunt or a stent, and the group that had a primary repair as a newborn. And that's always tricky. So that's why I think what Andy Glatz mentioned about this registry, where we'll follow those babies from when they're a newborn all the way until they're much older, will be a much more powerful way for us to really understand the true benefits. And as one of the other people mentioned on the chat, there's new technologies coming out now. So there's other ways to stent babies who are brand new newborns. This sort of delays the need for surgery. It's called RVOT stenting, and Brian had mentioned that. That may also change the outcomes in this population of newborn babies with blue tetralogy of Fallot. So there's more to learn than what we know right now, and that's always disappointing. You kind of want to know what's the answer, but sadly, it's kind of like this pandemic writ large. Every day you read a new paper about tetralogy, you learn something new, and it makes you ask 5 more questions that you didn't even know you were supposed to ask.
Awesome. Thank you, Chris. Next question is for Dr. Goldstein. For a family with a newborn baby diagnosed with TOF, how can they use the results of the CCRC's TOF study to help guide their decision-making on a management approach?
Awesome. Caitlin, thank you. Will, thank you. And to all the families who had a chance to speak tonight, thank you again for your participation and joining this session. I think it's incredibly impactful to me as a clinician, and I'm sure to other clinicians and families who are watching this webinar. So, I love this question because it's not easy to answer. I wish that this was a simplistic, randomized trial, and one group performed exceptionally well, and the trial was stopped in the middle of it because there was such a difference that you had to apply therapy A over therapy B in all cases. And I think the reality in so many studies in congenital heart disease is that there's a lot of moving parts. Differences between patients, differences between centers, and even differences between providers in the center. And that variability in so many components makes it hard to apply any kind of one size fits all sort of strategy to their management, which is hard to hear because you'd like to just have an answer and move on and apply that answer equally across the board. But instead, what we're left with, I think, is the opportunity to learn individual components of the study and apply those components to patients as individuals and unique people. So I do think one of the challenges to applying a study like this at different centers is that centers are different. And so if you're a center who's in South America, if you're a center who's in Western Europe, if you're a center who's in India, if you're a center who's in the US, you may look very different from each other. And to apply this study equally requires at least understanding that those centers can achieve relatively equivalent outcomes early with the 2 different therapies for the kind of rest of it to apply. And so that may be the case in many places, and it may not be the case in some places. So just understanding how to apply it, I think, requires an understanding of outcomes with the expertise that's available locally or regionally at the center. And then every patient's different. The anatomies differ. risk factors differ, size. We saw from Dr. Qureshi's study that small patients seem to do less well regardless of what therapy is applied. And we just heard about from Dr. Pettit and Dr. Glatzel, but about looking at patients who have small pulmonary arteries. And so I think it needs to be applied differently in the different populations. And some of the more helpful components of this work may actually be yet to come by looking at some of these subpopulations. And it may be that in the whole, there's a lot of equivalency in late outcomes. And it may turn out that when you look at the small pulmonary artery population or the small patient population or what have you, that there are actually learnings from each of those populations that do apply more specifically in those cohorts. And then lastly, as we stated when we were presenting, I think we still don't know the answer because we also don't know all the data that's important. And it's super important to look at how a patient performs in kindergarten and third grade and sixth grade and maybe in, college. And that may be different between these cohorts. And it's going to be a challenge because our therapies tend to evolve faster than someone goes from 0 through college. And so by the time we understand how someone's doing, we may be doing clinical practice differently. But these are all important challenges and ones that we're excited to sort of continue to take on with the CCRC model. So thank you for the question.
Excellent. Thank you, Brian. Andy, a question for you. How does the CCRC registry differ from other research groups?
Yeah, thanks. So I think, there's a couple of important differences between the CCRC registry and sort of traditional research groups. And the first thing is that the CCRC registry isn't only for research. I mean, we have research in our title, but that's because that's been our focus for the work we've done so far. What the registry allows us to do is to expand beyond just doing things for research purposes. So what's nice about a registry is that you're collecting data prospectively almost in real time, and you can sort of reflect those data back to the centers to try to help the centers understand where they fit in the kind of the overall landscape of the field and maybe improve. So, a big part of the goals of the CCRC registry is more towards the quality improvement side of things and not just on the research. So, we'll be able to show a center how they're doing with taking care of these types of patients compared to other centers through the registry. You can identify centers that are doing things differently than you, potentially talk to that center to understand what they're doing differently and why. But we still also have the ability to do research as well. The other thing I think just to say about traditional research groups is Chris Pettit explained it up front, is that sort of the way that we're organized in terms of sharing of responsibilities and that sort of thing is a little bit different from some of the traditional registries. And then the last thing is just to make the distinction between the difference from what we've done so far, which has always been kind of looking back at our past experiences up to the present and trying to learn something from that, to a registry which allows you to start now and then follow patients forward. This allows you to incorporate new innovations, new devices, new technologies quickly as they get introduced into practice and actually look at their results. So broadly speaking, that's sort of how I try to draw a contrast between us and other groups. Thanks.
Thanks, Andy. Next question is for the Rabori family. What do you hope the future of tetralogy of flow therapy looks like?
What we'd like to see it is consistent algorithms where if A, then B, and if C, then D, unfortunately, because there's 101 different varieties, that's unrealistic. What we really like to see is the knowledge of the treatments spread all throughout the country and the world even, so parents don't have to go through what we've gone through, which is unknowing of what's to be. So going to any hospital, any medical provider, and knowing where to properly direct their children. Unfortunately, like I said, there's 101 different varieties, so I'd love to have one surgery be done and never have to worry about anything again, but that's just unrealistic. Or anything?
No, you summed it up pretty well.
The thing I would like to research is how to get a 5-year-old to listen to you.
Yes. Amen.
Madeline, thanks so much for joining us.
Say hi, Ellen.
Thank you, Miss.
Thank you. All right, the next question. Let's see, who should we pick? We'll pick you, Brian. What are you doing as an organization, or what are we doing as an organization to spread the findings of the research?
Fabulous question. I love it. First, hi, Madeline. How are you? So I think that we are on a journey to learn how to answer this question. I guess the first answer is, I'd say, a webinar like this. We're very comfortable in the space of, I think, physicians, scientists who publish research in the medical literature, which has historically been the way to disseminate research. And I think the recognition that this webinar sort of heralds is that that's not a very effective way to communicate to a critical component of the stakeholders in tetralogy flow or other congenital heart diseases, which may be clinicians who don't read the medical literature routinely, and patients and families and friends of patients and families, and et cetera. So we're trying to bring a very cumbersome and scientifically difficult to articulate message to lots of different audiences. And this is our first go at that. And I think we've probably done some things well, and some things probably we have lots to learn. But I would say that this is our sort of continued journey into the realm of things outside of the medical literature, like using social media. We have a Twitter feed and a Facebook page. We are engaged with all of the families who are on the call tonight, and many more, including Amanda Brown, who's on the back end as a digital moderator tonight. So thank you to Amanda. But there's many families who are involved in this and helping our organization figure out how to spread the results of our findings directly to all the stakeholders that this matters for. And I think the continued version of that is we're now actively engaging those stakeholders at the beginnings of research so that we get it right more of the time with what we research, what questions we ask, and how we address those questions. So I'll ping pong it back to you to hear what you have to say about, how do we do this and how do we do it better? But that's my response. Thank you.
Well, that's not allowed. You're not allowed to ask the moderator a question, Brian. But I think that my response to the question would be much like yours, that we are learning, and we're just trying to do whatever we can to help as many families as possible. And so for those families that may be on the call that want to be involved, we'd love to have your ideas and your thoughts, but also your network, because so many other heart families that this could impact. And so getting to know you only helps to grow the message and strengthen the message. So please, please, please get involved if you're interested. Reach out to us at the CCRCresearch.org, and we will certainly get back to you and figure out how you can plug in. For those practitioners that are involved that have families that you may be thinking of right now that would want to be a part of helping to get the message out, we love to hear from you too, or your nominations of them if they would be so inclined to help us. So thank you to everybody who's made this happen tonight, but also to those that are interested in becoming involved. We want to get to know you, and we want to get to know your network of friends who could help to disseminate this and other important research to families to make informed decisions.
All right, we have about 5 minutes left of Q&A, so try to get a couple more questions in. Next one is for Andy. So as new technology and methods are introduced, how does that play a role in your ability to study early outcomes?
Yeah, thanks. I sort of teased at this in my last answer, and I think this, when you're looking at new technologies, broadly, there's two ways to do it. And one is to, if you're talking about a new stent, for example, it's to be in the trial that the stent company manufacturer is running to study the stent and get it FDA approved. So that ends up being a fairly tight-knit group of centers that are carefully picked. with, relatively restricted group of patients. And so the ability to learn anything, those are really important studies, but don't necessarily reflect the way that that device would behave at all centers throughout the whole community. So the other way to do it is to set up something like a registry, which is what we're obviously planning to do, so that when a new device or a new surgical technique or just a new approach starts being practiced by centers, that we have the ability to collect the information on that practice through the registry. In order for that to work, the registry has to consist of centers who are doing the new things and adopting new strategies and trying new devices. And so, we've been fortunate to have in our group of participating centers, a lot of really very high, both high volume and sort of high performing, high functioning centers that do bring some of the new techniques and devices and therapies, but also with enough spread of the, geographically and based on center size, that we think that some of the things that we learn from our group and from our registry would be more a reflection of what happens kind of in the real world and in the real community. And so some things that might be more relevant to most patients and families.
Thanks, Andy. All right, last question is for Brian. Hot seat for the last question. Did the results of this study apply equally across other CHD programs, including those that are outside of the United States?
Great question, Kaylin. I alluded to this a little bit earlier when we sort of talked about the results being generalizable depending upon ultimately local outcomes. And I think that this sort of remains true. The irony in this question actually is after we published our manuscript in the Journal of American College of Cardiology a couple months ago, we got a letter to the editor that will be published in the next, I think, month or so. And it effectively asked this question. The letter to the editor effectively said, in our region, which was outside the US, we don't have the same outcomes with the two strategies. We can't achieve great outcomes with primary repair. And so instead we do shunt and then repair later. And I think that, one has to identify local outcomes before applying any sort of balance and then asking a question. So it's critical to understand those outcomes. But the sort of alternative way to look at that is there may be other things in play that are modifiable that would be helpful or impactful for a region. For example, if it turns out when we study the cost of these therapies that one therapy costs less than another, well, if that therapy's outcomes in a particular center or region aren't as good as the other, you can't just switch to it to save money because you won't achieve outcomes that are equivalent. But maybe there's justification to ramp up some resources for a period of time to improve the infrastructure and talent to achieve those outcomes if possible, and thereby achieve those outcomes for less cost overall, which would be particularly beneficial in some parts of the developing world where there's less dollars in play. So I think, it's a long-winded answer to the question, but ultimately one has to know local talent and local capacity before applying a study like this. And I think that, everything's local. There's a lot of conversation in the US for a long time now about regionalization. And I think that comes into a conversation as well, as if there isn't balance between therapies, should all centers be performing therapies or should there be regional, centers of excellence? We won't get very far into that conversation tonight, but I think there's a lot that this kind of question opens up and a lot that our field has to provide in terms of answers over the coming years as we get further down the sort of maturity pathway as a field of congenital heart disease. So thank you for that question. Hopefully that answers a little bit, and I look forward to wrapping up. Thank you.
Thanks, Brian. So just to wrap up, wanted to thank everyone for joining tonight, whether you're joining live or watching this recorded. Special thank you to our speakers. Coming from a family member of a child with CHD, the research you are doing is impacting our lives and so many lives of families across the US and world. So thank you very much. Again, if you have any questions, please reach out to us. We'd love to have your involvement. answer any questions you have. And I wanted to kick it over to Chris and Brian for any final comments.
Thanks. I'll just say briefly to everybody who joined, thank you so much to the panelists. Your stories, your narratives, your insights were really, they were moving, very meaningful. So thank you for sharing those stories. And hopefully this will have been a meaningful evening for those of you who joined us from all over the US and the world, really. So thank you again.
Chris, I echo your parting comments. This has been incredibly personally meaningful and impactful to me to hear the stories from investigators and really families and patients who are impacted by this disease. We really hope that this has been meaningful to you, whether you're watching live or recorded, whether you have Tetralogy Flow, whether you care for patients with Tetralogy Flow, or whether you have interest in the disease for other reasons. We hope to be able to bring webinars like this from the CCRC to the greater CHD community on a regular basis. And we're really interested in contributions from you if you're interested in working with us, but also your feedback as to how we can make this webinar be even more impactful and meaningful to you and to the community in general. So thank you to those who participate in the call. Thank you for those who joined the call. And we really look forward to seeing you in a future webinar with the CCRC. Thanks so much and have a great night.